Hello, my name is Faraz Kadusi, and in this session, I'll be discussing clinician well-being. Now, I'm the Ambulatory Associate Chief Health Information Officer here at the Oregon Health and Science University and faculty with the Department of Medical Informatics and Clinical Epidemiology, as well as the Department of Family Medicine, and have my own primary care practice at the base of this gondola right here. Now, before my current role, I was a physician with the Air Force. Here's a picture of me with my crew in Kuwait. A big part of military leadership was embodied in the concept of putting your people first. So, technically, the core value in the Air Force is integrity first, but in all those officer trainings that we talked about, putting our people first, it was a sort of accountability for those that report to you. And given the nature of this conference, most all of you have that sort of influence. My intent today in looking at ways to put your people first within the clinical setting is to discuss moral injury within healthcare, previously called burnout, specifically framing it in the lens of clinician well-being in the past, issues we face today, and a look in the future. We'll start in the 1900s with the restructuring of medical education. The American Medical Association, the AMA, had been established in the late 1800s, and in 1905, they established a Committee for Medical Education. This Committee of Medical Education within the AMA commissioned the Carnegie Foundation to do an evaluation of the medical schools at the time. This report, led by Abraham Flexner, called for the closure of 124 of the 155 schools of the United States and Canada. Now, admittedly, medical education was in a state of disarray. There was no real identity, no common standards. And with the primary incentive of financial gain, you'd think that this be overall a good thing to a certain extent. The problem with this report was that it really laid the foundation of encouraging systemic racism and sexism, as there was clearly a preference for urban, well-resourced white males, and it called for the closing of most schools designated for African American students and all women's medical schools, which is clearly not okay. But still, this report ended up creating the framework that would become the foundation of medical education. They created this ideal triple threat physician, reinforcing the notion that all physicians should do it all, and that all other clinician groups, NPs, PAs, et cetera, have sort of started taking on a lot of this mentality. That we're modern day superheroes that can overperform in all related things. Plus, as technology and medical knowledge expanded over the last century, this triple threat ideal required clinicians to take on progressively more and more training and increase workload in order to maintain this multidisciplinary expertise, which created a really high pressure training and work environment with ridiculous performance expectations. It's a good thing we're not doing this anymore. I'm just kidding. This triple aim is seen in the shielded logos of multiple academic institutions. We continue to expect this multidisciplinary excellence in academic clinicians' time and workplace efforts, leading many to feel overextended or dissatisfied with performance pressures. Junior clinicians, in particular, struggle with this workplace satisfaction, especially if this multidisciplinary academic performance expectations don't align with what they want their professional trajectory to go with. Today, even here at OHSU, a lot of promotion processes remain a key challenge for many physicians in the academic medicine and really focus on these different aspects. So if it's something that I'm not personally interested, let's say in research, it ends up hurting the overall performance process. Now, as I previously mentioned, I have my own family medicine clinic here within OHSU. And although I work with residents and help with all the educational and research goals of my institution, my time in clinic prioritizes my patients. Now, I often explain to them my administrative roles as I'm worried about timelines for messages when I'm working on the IT group. But in the end, there continues to be a push to put patients first, which makes sense. Even after a full day working solely with the university's IT group, I often go back to the electronic health record at night after tucking the kids away to make sure there aren't any urgent messages or anything that really needs to be addressed immediately. And it's because of this history being embedded in everything that we do as clinicians. The role of the savior, doing it all to rescue the patient until this moral injury overall is so great, these whole groups burn out and realize that there must be some sort of balance that needs to be taken. And with that, we arrive here. Throughout the early 2000s, there were tons of social media platforms and new ways to communicate across groups. And this led a lot of patients to reach out through different means. and then led them to get this information online rather than the secure, trusted resources that they had in the past. Now, sometimes those medical resources are valid and it empowers patients in their personal healthcare management. But for others, access to misinformation online led to medical mistrust. Just a heads up, there are a lot of AI generated pictures from here on out, in case you're wondering what's going on over the next few slides with faces and hands and all that fun stuff.
Hmm.
So by the 2020s, this mistrust in medicine became so bad that some communities had sort of anti-science culture, which emerged. And it grew even worse with the pandemic. And on top of that, the politicization of COVID-19 prevention and treatment. And now you have these large communities that are really deferring public health recommendations to politicians rather than clinicians and scientists. And these politicians relied on this divisiveness to fuel their support. Then, as the pandemic progressed, patients flooded to the ER and the ICUs, and clinicians were asked to take on higher workload demands for the same patients that were against the system to begin with. Now, during this pandemic, I had the opportunity to be a public health emergency officer within the Air Force. And as I worked with my county counterparts, I saw firsthand how clinicians that use various platforms to refute medical misinformation and reinforce public health recommendations had become the targets of harassments and threats. Then, on top of that, you throw on the shortages in nursing, clinicians, medical assistants, and you're left with this huge burden that we've been asked to take on our shoulders. Then, just stacking on top of that, you have the corporatization of medicine with multi hospital acquisitions, increased regulations, hospital administration, all leading to this demand for conformity of practice with external productivity measures, and an increasing digital burden, making it even more difficult for them to disconnect, as I previously mentioned in my own situation. And you end up having this whole collective of clinicians that are really facing an uphill battle. A recent study from the AMA, Stanford, Mayo Clinic, and the University of Colorado School of Medicine found that overall, about 62.8% of physicians had at least one manifestation of burnout in 2021. And that's compared to 38.2% in 2020. And as a family medicine physician in the South Waterfront in Portland, I see it. I hope that the worst is behind us, but we've been taking care of our patients at the expense of our own well being for so long, it's difficult to come back from that. We continue to give, and the system continues to take, constantly letting us know that there's no financial stability at the institution, arguing about reimbursement. I don't know how any clinicians don't work after hours. Everyone adds extra time at the end of the day in order to make sure our patients are being taken care of. And when you're finally able to quote win the game, and for those of you that don't know, winning the game when you're a hospitalist is when you're able to sort of discharge all the patients and get everybody home. In the outpatient setting, is usually when we're finally cleared out all the messages, requests, charts, etc. It's a game everyone likes to play, but nobody wins for very long. Now, anyways, when you win the game, the system often rewards you not with anything else but more work, and it's often not reimbursed. And in the end, it involves patient care. The buck stops here because if I don't take care of my patients, who will? There's a sense of responsibility that's called us into this profession, but it's a trait that's often exploited to have clinicians do more with less. We're under significant pressure, and because of that, now is the time to take back medicine and create this vision for what the future of medicine should look like. As we cultivate this roadmap, there are many different filters through which we can develop how we want medicine to look in the future. And I would urge each of you, when establishing the vision for your own institution, to use a human centered design in guiding the way forward. I personally like to look towards Herzberg's two factor theory, looking at motivators and hygiene factors as the foundation from which to take decisions that influence change in clinical work. But investigating further, there's so many other institutions that are doing similar things that I thought I would share some of these processes. Just to give a little bit of context, you could really think of Herzberg as being sort of an expansion of Maslow's hierarchy of needs. It's not perfect, and given my military background, you should take it all with a grain of salt. But it discusses certain factors that cause job satisfaction, these motivators or intrinsic drive, and others that could cause dissatisfaction, hygiene or extrinsic motivators. These motivators enable people to derive satisfaction from their work and creates an intrinsic drive to improve their performance. Whereas the hygiene, the extrinsic factors, can be a source of dissatisfaction if they're not there, but they're not a reason to be motivated in themselves. So they're nice to have, but they don't necessarily improve the work done. And this could be a whole lecture on itself, but I just wanted to sort of give one of the frameworks that could be used overall in looking at it. Now, a more reputable and well-established framework comes from the Mayo Clinic. Now, the Mayo Clinic proceedings created this perspective that summarizes the historical phase of the journey of medicine, this era of distress, the current state, when it says well-being 1.0, and early contours of the next phase that really captures a lot of Herzberg's theory: meaningful work, recognizing individuals, finding what's important, giving input, etc. And we went from a time when a person's identity was just their profession as a clinician to being a part of what we do. Now, I wanted to share one of my favorite pieces of art. This right here. Like, how is this even a thing? Like, it's beautiful, it's well made, it's wonderful. I mean, that doc looks like me when I, before I had kids, good times. But like the thought of a physician fighting and winning against death, it really went all in with this era of distress, with the deity-like qualities, no limits, performance, that isolation. Just for fun, I've updated it to a more modern spin. There we go. And fun fact, in AI, if you write doctor on a computer in marble, they're all ripped. Just absolute, it's ridiculous. Anyways, going back, we've been seeing more of this work-life balance, and there's really been an acknowledgement by leadership that clinicians aren't doing well. The solution thus far has really been trying to increase resilience. And to me, resilience is kind of a dirty word. I don't like it. It's not fixing the problem. It ends up putting the blame on clinicians, and it doesn't fix the underlying systemic issues that are leading to this whole construct falling apart. It's the sort of strawman argument that has been causing clinicians to burn the candle at both ends and blame ourselves when it comes unraveled. It's one of the reasons why change from the phase from like burnout to moral injury to better describe this death from 1,000 cuts being described in recent Medscape reports. And it's a way of finally placing the blame of the process rather than placing the blame on the individual clinicians. So let's fix it. Given the multiple stakeholders, it's up to us as organizational leaders here at HIMSS to help come up with solutions. As you've seen, there are many ways to frame this problem of moral injury, but the goal of incorporating tech should simply be to make it easy to do the right thing for the clinicians. That's it. Now, different institutions will define right and easy differently depending on their goals, but that's what we need to overall do. As we move into this world of Wellbeing 2.0, the Mayo Clinic proceedings goes through a whole list of steps across the spectrum, and I'd encourage you to go take a look at it. But it discusses the care to show where we were, where we are, and where we should go. Some of the main steps that I'd like to bring up in this sort of future in healthcare is the humanizing of clinicians in order to set expectations and roles, to build up that clinician and administrative partnership so that we can remove this adversarial relationship that many clinicians experience, which also creates a more sustainable system and improves overall work environment. And finally, looking at technologic contributions that can help bring about this new era in medicine. I've explained that a lot of what I see in the primary care setting, in order to come up with a process that will actually work long term, we really need to reframe the way that we see primary care. Instead of trying to increase the supply, which isn't happening anytime soon, like, let's be honest, we need to decrease demand. We're still seeing patients, but this reduces the work that we're doing after hours. It reduces unnecessary administrative burden in the clinical practice, and it allows clinicians to spend their free time freely, which is the intent. The US Surgeon General, Vivek Murthy, listed burnout as one of his priorities and notes reduction of administrative burden and increase in human-centered technology as possible solutions. So how do we reduce a lot of this clerical work? Well, an AI-enabled triage can help us shuttle patients to appropriate clinical staff, which will both take the burden off the clinician, but also challenges others within the clinics, which supports the Herzberg motivators. We can work towards automating notes. We can simplify billing. We can make it easier to get prior authorization, and finally sort of demystify a lot of the insurance process and make chart review a lot more straightforward by prioritizing the most applicable findings. So here at OHSU, one of the processes that we've actually started was this targeted optimization team that goes from one clinic to another, finding ways to improve the electronic health record within clinical workflows. It's been on pause with the pandemic, but has come back with a vengeance this year. We're having discussions to improve triage processes, reduce clinician burden with reducing in-basket messaging, improved clinical decision support, and just taking those baby steps in order to make it easy for the clinician to do the right thing. That's it. So we've gone over the history and current state of clinician well-being, as well as a vision for the future. In the end, it really does end up being a change in the culture that will help us move towards this new world of wellness. So as you leave today, think through what you can do in your own organization to make the changes necessary to put your people first. Thank you so much for attending. If you have any questions, if you haven't entered in the Q&A, feel free to do that now, and we'll take a look at what we have going on.
Wow, well, thank you, Dr. Degucy. That gave us a lot to consider, speaking for myself. Audience, we have Q&A enabled below. Please add your questions as you think of them. Also want to let you know you have the opportunity to submit a question anonymously. If there's anything you've ever wanted to ask and weren't comfortable doing so, now's your chance. Dr. Gadusi, while we wait for questions to come in, may I ask you, you approached us to be able to talk about this particular topic. I know you're an informatics officer as well as a practicing family physician. So how did you pick this topic over others for what to talk about today?
So this is a huge problem that we see in the outpatient setting. I see a lot of my colleagues being burnt out. I know that there are a lot that are creating projects, and we have one that's actually a fellow with the AAFP working specifically on burnout and physician well-being. It's a very timely subject. It's something that everybody's feeling, and with the pandemic, to be blunt, a lot of people that just didn't want to deal with it anymore left the profession. So we end up even more short-staffed, and the people that we do have are being overworked. So it's a way of sort of reinforcing everything that we need to do in order to make sure we take care of the people that are still here.
Wow, so burnout is a burning issue in essence.
It's good.
So sorry to say, right? So related, interesting, our first question from the audience connects to this. So someone's comments are that they tried to institute change and ended up then retiring 3 years ago because they weren't being heard. And now they're also looking for a good time to get back in. This is someone who doesn't want to stay out forever. So what would your advice be then to someone in that situation? I guess both someone who's still in the system looking for reasons to stay, or somebody who's on the sidelines now waiting for a good time to get back in.
So I would always encourage everybody to do what they can. So although you may be out, you could bring baby steps back in if you wanted to work part-time and that kind of thing. It all depends on individual motivators and what your goals end up being. But in terms of looking at the systemic issues and how we could fix everything else, if the reason for leaving ended up being institutional problems, finding ways to change the institution. And I know it sounds difficult, but coming from the military and going to the academic world, it's a lot easier. Like, it's funny what the bureaucracy of each step ends up being. It requires very intentional steps because it's very easy for clinicians to get sucked into the clinical world because that's what we love and that's what we know. You could work your 8 to 5 days a week, just seeing clinic back to back, but that doesn't really change the overall process. It becomes difficult to find that dedicated time, but a lot of institutions are looking for clinician leaders to help the administration with a lot of these things because they're seeing more and more wisdom as they're seeing success in other institutions where they're really bringing the clinicians into this decision-making process. So finding a way to make your voice heard in whatever organization you're in is going to be key to really making the changes that you want.
Wow, well, that begs some follow-up questions. In terms of advocacy, what do you think the responsibility is of provider groups versus individual clinicians?
So I love provider groups because it gives big bulk voices a say. As an individual clinician, I do reach out to state representatives just because it's easier to make that one-on-one contact. But in the past, because I'm a family medicine physician, I worked with the local AFP chapters in order to reach out and talk to our legislative leaders, because when we end up having those numbers, they see that there are a lot of us making those decisions. I know that there's a lot of controversy with certain clinician groups, so some people may disagree with certain aspects of what that group may believe. But usually, overall, it ends up being a sort of consistent theme of trying to take care of the patients and finding ways to improve the processes, improve the rules and regulations in order to do so.
Okay, and that also suggests a question of how is this being discussed in medical schools today? How is it being approached now, and how are future leaders within the physician ranks organizing themselves?
A lot more of the medical schools are starting to incorporate this into the curriculum. There still ends up being, I mean, it's very rigorous training. It's very difficult. It will continue to be difficult. But you're starting to see more and more glimpses of humanizing the clinician. And with that, you're seeing this sort of shift in the new generations of how to not just take care of your patients, but take care of yourselves. It's a new era of medicine. There's just too much information to know everything. And every year there's more and more that comes out. So everything that we knew a decade ago, like, yeah, most of it's true, but there's a lot more that's come up. So having to stay on top of everything becomes more and more difficult. It's impossible to know everything for everyone. So accepting that, taking the best care of your patient, and making sure that you have the resources available to you in order to help others is going to be key.
Well, that leads very nicely to our next question. This individual suggests that we have government and policy changes that are always happening that are outside the control of any individual or group, and asks, what are the three top things that a provider group or clinical setting could do today to improve physician well-being in 5 years from now?
So one of the best things that we could do today in order to overall improve quality is it really is important to collect data and analyze all of the patient outcomes. By having those cold facts, we're really able to sort of move forward, and when we present options, ideas, etc., we have either patient-oriented outcomes or overall well-validated studies to say this is what we need to change, this is why we need to change it, and it becomes difficult to argue against it. Um, we should also start focusing more on patient engagement. A lot of our patients really want to participate in their own healthcare, and really they don't know how. So giving them trusted, reliable resources, helping them take care of themselves is going to be really key, especially in the primary care setting. Obviously, this doesn't apply in like for surgeons, because that's not one of those DIY projects. But if you're able to like have them take that ownership for what they need to do, help educate them, I really see our role changing, especially in primary care, as more of the educators. And three ways you said. Another one's going to be getting involved with your either hospital administration, organization, or statewide legislature. We really need to make our voice heard. If we don't, we're just going to continue repeating everything that we've done in the past. So if we don't like it, we need to speak up.
Makes sense. So you mentioned outcomes, and that leads nicely into another question here about how it is that you're measuring or gauging burnout, and how are you then validating that tool?
So there are a couple of currently validated tools. One of them is the Maslow Burnout Inventory, and that's used pretty regularly. There is the Mayo Wellbeing Index. That's more psych focused generally, but that looks at risk for burnout, which is nice. And then there is the Mini C, which is a one question. And so there are a lot of different ways to look at it. Another thing that we're looking at here locally with the electronic health record is we joined the Arch Collaborative with class, or the Arch Collective, in order to look at how physicians are responding to changes in the EHR.
So that looks like another ripe avenue for measuring outcomes and looking for improvement based on how the interventions to protect provider well-being are working.
Yep.
Okay, good news. So here's a question that's going to be maybe challenging, but I want to take advantage of the fact that you have two hats here that we can probe. We have the practicing physician and we have the administrator in you. So when you switch hats and you look at the situation from administrator's point of view and you look at the suffering and you want to do something, where do you think you can help? And where are you seeing that you can't? And it's a matter of wishing you could do more, but there's just some existential issues that you won't be able to address.
Right. Again, the biggest thing is just having the seat at the table, right? It If you're not at the table, you're on the chopping block, and that's really the biggest concern that a lot of clinicians have, because if you're not in those discussions, when those discussions take place, there's nobody speaking up for your best interest. So with that administrative aspect, I'm able to sort of speak up for our clinicians, speak up for our front lines. Half of my FTE is clinical work, so I'm in the clinic half days a week. Because of that, I'm seeing firsthand all the issues and problems that end up coming up with that. And really, it's sort of kept me grounded in terms of things that need to be fixed. It's made me much more available and accessible to all the other clinicians, so all the other family medicine physicians know where to find me, both in person and text. So it really helps open that up, because once there's that clear line of things that everyone wants and needs, and having that sort of ivory tower where you're making decisions for the whole institution, especially at larger academic institutions, you need that relationship and something to keep you grounded. So yes, I have that administrative hat, but it ends up being the clinical hat that keeps my ears to the ground and makes sure I know everything that's going on with our people.
That's wonderful. So audience, we have time for more questions if you want to throw some more in. Let me ask you to follow up on your comment about resilience. So I'm a behavioral health clinician. I appreciate the importance of that. Can you talk about your observations? When do you observe that clinicians do need help building up resilience? How do you differentiate that from when it's the system?
So it's hard to parse those two things out easily. Every once in a while, you do see clinicians that are just overburdened in general, and it becomes difficult for them even at baseline. But often it ends up being systemic changes that are really pushing that person to that edge and showing more and more of those signs of burnout. Um, it's multifaceted, and really a lot of people might focus on one or another. So it's not just that sort of physical exhaustion, but it's the emotional and mental exhaustion as well. And there, for most clinicians, there end up being this like honeymoon phase when you're first out of residency, you're an attending, you start to do everything. And then over time, you start to have that increased stress and increased burden, and then eventually you end up towards that burned out session. And we sort of accepted it, right? So because it's seen as sort of this timeline of how clinicians end up practicing, unless you're, lucky and you have your ideal practice, it's hard to do. So it becomes difficult to really separate those two. Is it the clinician versus is it the system? Which is why it's so easy to blame the clinician.
Mm.
Yeah.
The nature versus nurture almost argument in a way. It's the answer is both, or always look to the environment. Certainly that's the mantra in quality improvement, is look for the system changes to make before you identify an individual. Okay, we're closing in on time here, so let me just ask, if you were asking someone to bring home one concept today, one top takeaway that they bring back to the office or as they think about this, what would that be?
Really, the biggest, most important thing is to just make it easy for the clinician to do the right thing. Whether it's building workflows, whether it's creating a system, evaluating electronic health record, adding tech, um, making it easy to clinically do the right thing is going to be the most important thing. we continue to see more and more regulations and rules and things like that that are sort of weaving into clinical practice. Finding a way to make those seamless is going to be one of the most important things, because it'll be difficult for clinicians to stop that or change that, but there are ways to change the system to reduce that burden.
Makes so much sense. Well, thank you so much for putting together this custom topic just for our 10th annual Innovation Conference. And welcome back to Northern California, Dr. Gadusi. Really appreciate you sharing your wisdom with us today.
Thank you for having me. Appreciate it.